Hello, everybody, and welcome to the last remote lecture of this unit. So I'm going to finish up my content in the video series that are posted on D2L for this week. And next week, we have a guest lecture coming in. So that will be outside of the outline, and you'll have her PowerPoint slides available for a kind of pelvic floor dysfunction talk. So we're going to pick up where we left off, and we were talking about cerebrovascular accidents, CVAs, also known as strokes, and we've gotten through all of the ischemic strokes, when blood flow is blocked to a section of the brain, and then the ischemic damage and cell death that occurs. The other kind of stroke that can happen is a bleed. So a hemorrhagic stroke, as it says in your notes, is bleeding from an arterial source into brain parenchyma. And of the two strokes, the hemorrhagic is the most deadly. This is a really hard stroke to survive and recover from. Someone can have a primary hemorrhagic stroke when there's no known cause, just spontaneous bleeding with no obvious precipitant, nothing you could point to that said this is why it happened. A secondary stroke is in response to something else. So obviously with trauma, if you hit your head, you can get a hemorrhagic stroke. People who have impaired coagulation, whether it's a genetic impairment in one of their clotting factors or long-term anticoagulation medication that could lead to the bleed, and other things like that. I just want to point out in the notes section, I have, some of those numbers and facts that go with the stroke. Again, these are not to be memorized, but this is kind of less common. It's 80,000 strokes per year for a hemorrhagic stroke. It's very uncommon in the young. So very low incidence when you're less than 45 years of age, and significantly goes up when you're above 65. And we see increased frequency in epidemiological studies when it looks at males, African Americans, and Asians. So if you turn the page, we talk about how bleeding into the brain actually damages brain tissue. This picture on the slide is obviously a patient who died from the hemorrhagic stroke. The reason the blood looks black is that the person is deceased and the blood is coagulated, and that's what old coagulated blood looks like. So all of the black in the brain here is the bleed. I like this picture because I think it really helps to illustrate the primary damage of the hemorrhagic stroke. And the primary damage is kind of mechanical in nature. The actual physical changes within the brain. By that I mean, when an artery ruptures and bleeding happens in the brain, the blood takes up physical space. And I think this picture really illustrates it well. Your brain is in a closed cavity, right? It's got a shell on it, a thick bony shell. There's nowhere, you can't add anything else in that enclosed cavity. And now we're pouring blood into it. So blood is going to physically take up space, and that is going to raise intracranial pressure. Intracranial pressure goes up. Basically, the blood takes up space, causing the pressure to compress your brain tissue. And you can see that on the side. The brain tissue just got squeezed. Well, that's a mechanical trauma to a cell. If you smash a cell, you create really high pressure outside of a cell, you will damage and injure that cell. So because the brain is in a closed cavity, the rise in intracranial pressure physically squeezes cells, and that's a mechanical damage, right? Same thing if somebody smashed your ankle with a hammer, that would be mechanical damage to your ankle. There's a mechanical property to the damage that happens to a hemorrhagic stroke. In addition to that, there's secondary damage. Now, it's really important to remember that our brain tissue is carefully kept separate from our blood in what's called the blood-brain barrier. We have much tighter junctions of our vessel wall in the brain than anywhere else in the body to keep blood elements out. So blood itself is cytotoxic. The blood itself kills neurons and glia. Specifically, for those of you who are interested, the hemoglobin in the blood and its products, heme and iron, are potent mitochondrial toxins. So you're basically like pouring poison on blood cells because you could think of the blood as being a poison for neurons and glia. So when the stroke happens, blood is pouring into an enclosed cavity, an enclosed space, like inside your cranium, pushing the brain tissue up against the walls, physically squeezing, there's the word I'm looking for, physically squeezing the cells, right, causing a mechanical damage. But on top of that, the cells are being exposed to a toxin that will cause them to die. And in response to this, we see deadly brain edema. And the reason that deadly is on there is because the edema is in response to all of the tissue damage from the blood. But then the edema itself is more fluid in the brain. And this is so awful for the sequelae of this disease, because they already have the primary mechanical damage of the blood, and now we're adding extra liquid into the brain. The edema will continue to rise. It increases a lot in the first 24 hours, but really the edema peaks at about day 5 to 6. Day 5 to 6 is the kind of the peak amount of edema. So these patients are not out of the woods. You know, if they survive the initial stroke, there is a lot of managing that happens in the days afterward, because the injury is ongoing as this edema is creating increase in the space and taking up pressure. So our patients who have hemorrhagic stroke are very carefully monitored. Their intracranial pressure, from the lines and monitors we talked about the ICP monitor, the intracranial pressure monitor. This kind of looks like a little radio antenna coming out of the top of their head. Katie had talked about how important it was for positioning of the head if a patient has an ICP monitor. So you find this on almost any patient who had a hemorrhagic stroke, because they're really watching to see how pressures change in the hours and days after the stroke. So treatment for a hemorrhagic stroke is very much related to the damage that has been caused. So they will sometimes drill holes into the cranium to release that pressure. They give treatments that systemic medication that can try to draw fluid back into the blood vessel. Like adding a lot of sugar into the blood is actually like osmotically active to pull the water back into the blood vessel. So they do other treatments to try to pull it out, and anything that can lower their blood pressure. They're going to be on meds to drop the blood pressure down, because the lower the pressure, the lower the pressure behind the arteries that were leaking and bleeding. So that's kind of the overarching goals of hemorrhagic stroke is release the pressure, try to get the fluid out as much as you can, but you're really limited with that, right? Because you're inside of the brain. And then lower the blood pressure as low as you can so that there's no pressure behind the leak. Now, you'll see in the next section in your notes, it says D, clinical manifestations. We're kind of going back to putting all strokes together, because the initial signs and symptoms of a stroke are the same. You don't know which stroke you're dealing with. I'm giving you a very, very simplistic list of the signs and symptoms. These are basically the signs and symptoms that are used for public health to let everybody know. The public health messaging is to try to encourage anyone to be able to recognize the signs of a stroke, because time is tissue, and the longer it takes to get to the hospital, the more brain tissue can die. So evidence that someone is having a stroke can very commonly include paralysis, impaired speech, loss of vision, or severe headaches. for those of you who want to know so much more, you're getting a ton more of this in your future. So the real signs and symptoms of a stroke are completely dependent on what part of the brain has the ischemia or the bleed. So by the time you are through with the PT program and through your neuroanatomy class, you will know all of the areas of the brain and what they do. And then you'll apply all of that in neuro rehab to truly be able to look at someone's signs and symptoms and actually, in pretty good accuracy, tell where the stroke was. So this is all coming in your future. I don't want you to think that this very short list is what you're getting on stroke. This is simply the place where we introduce the initial pathophys of the stroke. All right, we got through arterial pathologies, so disorders on the artery side. Now let's spend a little time talking about the veins. So let's go into the venous side. First, let's just review the anatomy. A vein is very much similar to an artery. So on the picture here on the left is an artery and on the right is a vein. A vein has the 3 layers of the walls of the vessel, just like an artery, right? It has the adventitia, the outside kind of collagen that supports it. Veins do have smooth muscle, and this is important. It'll matter a lot with exercise, because when we exercise, one of the things that happens is we actually get constriction of our veins, which helps with venous return. If you look at the thickness of the wall of this muscle and compare it to the thickness of the muscle wall of the artery, you will see there's much, the veins have much less than the arteries. Our arteries have much thicker vascular walls, but there is muscle in a vein. Veins have the tunica intima, the single cell layer of endothelial cells, just like an artery. The big difference that you can see once you look at the inside of the lumen is the presence of valves. Valves serve a very important role in veins because the blood is traveling back to the heart in the veins. So many of our veins, most of our veins in our body, gravity is kind of working against us. So the blood needs to go up, kind of against gravity. And if there was no valve, it would continue to fall down into our feet. We'd have a hard time kind of making progress, moving up let's say the highway of our veins. But when the skeletal muscle contracts around this vein and it pushes in, blood goes up. And then when the skeletal muscle around the vein relaxes, and gravity might want to pull that blood back down, the valves snap closed. And in that way, it prevents the blood that got into this section from regurgitating back down into here. So we kind of, in a stepwise manner, move blood up the veins. Every time we contract the muscle, it kind of moves up a little bit. As gravity would like to bring it down, the valves snap closed. When the skeletal muscles contract to move blood up, the force of the blood flaps the valves open and blood can move up. So the role of valves in the veins is very significant and important, and it actually leads into our first pathology, which is varicose veins. Varicose veins can be seen in this picture. You can see evidence of the dilated, tortuous veins. Means that they often kind of aren't in a straight line anymore. They're all squiggly. It's most common and almost exclusively found in the lower extremity. And the main mechanism of the varicose vein is related to valve incompetency. The valves stop working right. So again, another picture of a person with varicose veins here. In a normal vein again, right, the closure of the vein prevents backflow. The blood that gets past the valve will not regurgitate down into this section. If the valves cannot close, there's nothing really stopping from gravity from sending that blood back down. So the valve is the primary problem. And if you look at the risk factors that are in your notes, it talks about periods of heavy lifting, sitting and standing, hormonal changes. This is very commonly precipitated by pregnancy, and obesity. Okay, so something heavy lifting, big belly from a pregnancy, big belly from obesity is a leading factor. Let's keep that in mind, and let's draw through the pathophys of varicose veins. And just look for a second at this picture. I'm going to go and I'm going to draw a little cartoon to draw as I talk, because as you guys know, I think better when I'm drawing. But let's just look here at the anatomy of the veins before we jump over to cartoon land. So we've got the inferior vena cava right up here at the top that's collecting all the blood from the lower extremities. It splits into the common iliac veins, which then split further into external iliac and then femoral vein. Now, what's an important thing to note is that the inferior vena cava, this guy, and the common iliac vein, these guys have no valves. Okay, so those big, huge veins at the top do not have valves. What that means is that all the blood in those tubes is actually being held up by the valves that are in the external iliac vein and the femoral vein. Let's go to the cartoon, and I'm going to draw this out so you can see it another way. So let's draw just kind of a person on here. Here's their body going all the way down to their legs. Okay, so the inferior vena cava, big, huge column of blood. And then we'll just kind of simplify this and have it split down here. So let's say we're into the femoral vein. The femoral vein has valves. Let me draw this vein all the way down. Get smaller, get smaller. So the femoral vein has valves. Here they are. I think I should have made this a little bigger. But at this point, all of the blood, right, that's here and above, all the weight of this blood is being held up by the very top femoral vein valve, the femoral vein valve. So if you kind of peek back at your notes, the risk factors for varicose veins, periods of heavy lifting. What do we do when we lift something heavy? We bear down, right? You contract your abdominals. That is not slang I normally use for abdominals. That one just popped out, but I kind of like it. The abdoms. You contract your abdominal muscles. You contract your diaphragm, right? You hold your breath and you create really high amounts of intra-abdominal pressure. And that's great for heavy lifting because you stabilize your core. You create a rigid tube basically around your spinal cord. So all that mobility of our middle section, synced up. But you raise your abdominal pressure. Good for lifting. Probably not great for this little valve here that's holding all the weight of the blood above it. As you increase abdominal pressure, what are you doing around these big central veins? You are squeezing them and increasing the pressure in the central veins. What is bearing the brunt of that pressure? Central veins. There we go. That little femoral vein valve. So periods of prolonged standing, where you're having all that gravity holding that weight on that femoral vein valve. Pregnancy. Pregnancy, we actually will talk about a lot in fall and phys ed activity, but pregnancy, you get a very high blood volume. You increase your blood volume like crazy. And then you put a big old bowling ball basically right on top of your central veins. This is going to increase abdominal pressure and increase the pressure in the central veins. Obesity is a very similar mechanism. The weight of the central adiposity, the weight of all the fat cells sitting on top of those central veins, increases the pressure and exaggerates the load of the femoral vein. So what happens next? The repeated increased abdominal pressures from whatever the cause stresses the valves of the lower extremity veins. And prolonged exposure leads to valve incompetency. So instead of, maybe on the other side, I'm going to draw my dysfunctional side over here so that I don't have to erase anything. I have learned over time that students who are drawing along with me do not like it when I erase, because then your notes don't make any sense. So let's make this side our good side. And we're going to give varicose veins to the right side of the screen. We'll make it all orange over here. So over time, the increased weight and strain on the valves at the top of our leg veins, right, our femoral veins, our external iliac veins, cause valve incompetency. So I'm going to draw those as little squiggly lines. By that I mean they no longer are going to be able to snap shut. They lose their spring back and they're ineffective at supporting the weight of the blood. So what happens if your valves can't close and it's supporting the weight of all the blood above it? You're going to get reflux of blood back down, right? Blood is going to reflux down, and it's actually going to stretch out the walls of this vein. Well, now you've got two problems, because the valve is incompetent. And let's say you had a valve just below it that was still normal. So I'm going to draw these as straight lines. They were still healthy because they weren't bearing all the weight, right? They were protected by the valve on top of them. But now you've stretched out the walls. The valves are attached to the walls. So you've pulled them apart from each other. Now they don't reach. Oh, that was messy. Let's try that again. Look between these guys. There's a space here, right? They might not be dysfunctional yet, but they can't close because the whole vein has been dilated. Well, this is going to lead to further reflux and further stretching of the walls. The vein's going to get bigger. So the valves, downstream, even further apart, totally unable to prevent this backflow. And you end up getting these enlarged veins that over time lose their structure and then become, tortuous and squiggly because they aren't held in this nice straight column anymore as they undergo changes in the wall from this repeated stretch and pressure. So varicose veins is kind of the underlying problem is valve incompetency. It's frequently caused kind of related to our anatomy, right? The fact that we were designed in a way that our central veins don't have valves. So all the weight of our central vein blood has to be held up by our most proximal valves. So if there's any condition that raises abdominal pressure over a chronic period of time, right, day in and day out, stressing those valves that are supporting all that weight of our central blood, the valves just will ultimately get beat up by that pressure and become incompetent and damaged. And once you've damaged your valves, there's sort of a slippery slope that happens because the reflux of blood will stretch the walls, and now the valves that might still have had integrity in terms of their strength of the physical properties of the valve might be fine, but if they're so far apart from each other, it doesn't matter if they move up or down, they can't seal the deal, and blood will reflux down. So I like starting from this picture to remember where we are and the anatomy of the veins and how that plays into the pathophysiology. So what does this look like or feel like for patients? Varicose veins creates a dull, aching heaviness, sometimes described as almost like a tension underneath the skin. Can frequently cause cramps of the lower leg. Patients will typically find symptomatic relief if they elevate their feet above gravity. So the whole reason, right, that blood is refluxing down through these incompetent valves is that gravity is pulling it down, right? Gravity is the force that's trying to pull the blood back. So if you tip this up and allow gravity to basically work in the other direction, you can help pull blood out of those veins and take the pressure off the walls of the veins. The response to this overstretching, overpressurization of the veins, the walls of the vein become thick, they become hard to the touch. This is also a very frequent cause of thrombosis. If you have refluxing blood and stretched out walls, so you're not effectively moving the blood as well as you would, that is a breeding ground for a thrombosis because you can't effectively wash out your clotting factors. The term phlebitis has itis in the name, so you know it has to be an inflammation. This is an inflammation of the vein. The veins can become inflamed from the stress of the increased pressure. Venous insufficiency ulcers. Whenever someone uses the term insufficiency, it's telling you that that thing isn't doing its job right? They're insufficiently doing whatever they're supposed to be doing. So venous insufficiency means that there is a lack of venous flow. So if there's a lack of venous flow and you can't get the blood moving kind of out of the tissue area, that's going to lead to congestion. So if you had if you're thinking about Starling's forces acting on a blood vessel, we are assuming that blood can leave on the other side of this through the veins. If there's something that's preventing venous flow, that can increase the hydrostatic pressure in the capillary behind it and can lead to fluid leaking out. So venous insufficiency ulcers, ulcerations of the skin, can occur because of the congestion that occurs related to fluid leaking out. So for PT, it's good to know that conservative treatment for varicose veins involves activity to promote circulation, teaching patients to do frequent posture changes. Sometimes they'll wear like elastic stockings for support, because if you can create external pressure outside of the vein, that can help keep venous blood moving. In general, the recommendation is to avoid high impact exercise. Example would be like running and jogging. That's because with every step, that big impact, right, is now you're creating gravity and a force kind of pushing blood down, and it can exaggerate the stretch on the wall of the vessel. So it's much better if you can do low impact activity that promotes circulation but doesn't have that jarring impact. I'll opt for surgical interventions. Most recently now, it's almost all done by laser, where the laser actually closes up some of the large, really tortuous veins. These are veins that are no longer really functional, and by closing them down, it allows blood flow to move through the functional veins. It's very good for symptom relief. Patients respond really well to this surgery. All right, so we're at about a 30-minute mark for this video. To keep these in little short chunks, I'm going to stop the video here, and then we'll pick up the lymphatic system on the next video. Hope you're enjoying it. Bye.